77 is good, nearly horizontal. रोशनी देखेंगे, दोनों आँख खुली रखेंगे, आँख नहीं हिलाएंगे. Now I recently have acquired a knife which has a mark at 1.5 millimeters. And that's a good, a very good index that this is the point where you have to tilt your knife to go in. See this lipid layer? This is mebomitis. Now we should actually note these things and give them a treatment for this. Mebomitis is treated by hot fermentation, ringer, and hot fermentation, steroid antibiotic eye ointment applied at the lid margin, and a doxycycline. Doxycycline is a kind of antibiotic which is actively secreted in meibomian glands. So that will take care of few more things if there are infections. Basically, it is lipid secretion which is having a higher melting point, plus the temperature of the winters, it causes the solidification of that. Now yesterday I was operating one case and the chamber was very shallow, so my rexes went out and I thought that we can visco and I thought that maybe I can pull it back. So using brute force I tried to pull it back. It didn't came back. So instead it went out and out and out. I was not so careful. I didn't bother much. So I started my phaco. Somehow I completed it by pulling. I never bothered what has happened next. And there was actually a zonal adhesions. So the moment I went on to disassemble the nucleus, there was a big opening in the inferior temporal part, and there's a whole of the nucleus inside, and that makes it a very bad situation, because if you have nucleus with a large PC rent, it will go down. So what is the lesson? The lesson is that complete your capsular rexes, whatever cost you have to bear. But the shallow chambers, they are notorious, because if you are a shallow chamber, then the rexes, controlling the rexes become even more difficult. Now this has been well battered. Can you see? People have chopped this. Maybe if I am only the person who is using, then I might have chopped it. But I usually don't do phaco like this. So this portion being chopped is unusual. I do my phaco. No, sorry, I do it like this. So this is fine, but this should not have been chopped. And actually, you can see the asymmetry. This is more battered than this. ये टिप चेंज होना चाहिए. नोट कराइए मानसी को. इसने अपनी उम्र काट ली. So these are actually consumables. So they will wear with time and you will have to change them. But somehow our staff and our office, they feel that once you have purchased a phaco tip with a machine, it will work forever. So if you are methodical enough, then phaco is not a difficult surgery. See, we did a nice primary chop, and then you again bury. Let it go into a particular depth. Then your chop is easier. And then you break it into further pieces, and you keep on chopping. Rotate engage, chop. Make sure the pieces are separated out. We'll keep on doing this till we have very small.
जब engage करते हैं तब vacuum तब chop कम फेंको तो नहीं हम hurt से तो नहीं जाते हैं.
आप सुनो आवाज. I'm doing it in front of you. Try to appreciate. So we aspirate, power, and you stop. Then you chop. And if you think that your piece is getting dislodged, then you can again apply power. And then you leave it again. And then you again engage some other portion. Chop. Power off. And now you have these small pieces. And now Dr. Shivani will consume them. Come. Or maybe I'll consume few so that they are free. That's the important part, because they have to be freed so that they come to you easily. So in Phaco mode 2, where you have micropulse mode, you engage them. I can see that my iris is prolapsing out. I'll not worry about that much. That wound is too small for iris to get traumatized. So keep your focus well, little away from the PC, more toward the pupillary plane, and whatever piece you pick up, it should be free. Then only it will get oriented and it will float around. So if it is engaged, you push it away, push the parent part away, and then now we have 1 and 2 and maybe a little portion here, 3. इसको दीजिए. Now, first thing which you do is you align your view. Microscope has to be properly aligned for the pupillary plane. Are you familiar with the foot switch?
Yes.
Yes?
Yes, sir. Aspiration. Irrigation, aspiration, then
Power is twisted. This is very important. If you would have said no, then I would not have given you this place. So now you come, go inside with bevel down. When you go bevel down, you keep the tip inside the incision, just a little bit. Why? Because the moment you will turn on the irrigation, patient will have some bells and the eye will move up. So if you are not engaged yet, you will slip. So engage your tip. So now when the patient has bells, he is actually pushing the eye towards your tip. So it aids in going in rather than slipping away. So when you are in with irrigation on, then you switch it, rotate it 180 degrees so that the bevel is up. Right? And then you start aspirating, because pieces are free, so they will float around and they will come to you. Once you see that something is close to your tip, then you engage power. When you see that nothing is in front of your tip, you stop power. So it's like going down, twisting, coming back. You can keep the aspiration on all the time, it will keep on circulating. So I'll be looking at it, you do it, I'll hold your hand if you are in a problem. IPD focus. Now this has a monocular view, so I don't have any depth perception here. Dialer दीजिए. What I'll do is I'll rotate the pieces so that they are aligned to your phaco tip when you go inside. So I don't have depth perception, but still I can manage by touch. So now they are diagonally opposite to your entry point, so that when you approach them, you hit them. You may not need a chopper right now. Bimanual manipulation is little more difficult and more demanding. है ना, दोनों just use the phaco tip. टेस्ट योर फुट स्विच. इधर रखो, इधर रखो, इधर रखो. ऑन, इरिगेशन ऑन. नहीं, एस्पिरेशन भी हो गया ऑन. केवल इरिगेशन ऑन करना है. ठीक. दिस इरिगेशन ऑल्सो. Engage just aspiration. When your aspiration is on, it will ting ting. When your aspiration is on, then it is this. And the tone will change depending on the amount of foot switch travel you have. Power on करो. Power off करो. नहीं, इतना ये नहीं होना है कि आप दबा के बैठ गए. ऑन करो, ऑफ करो. You should have command over it. Power on, off, on, off. Now aspiration off करो. कॉर्निया वेट करिए. व्यू सेंटर करो. व्यू सेंटर करो. अरे फुट स्विच से करो. अभी बोल रहा हूं, अभी आपकी लेफ्ट आई भी प्लान है, राइट आई को भी प्लान करेगा प्रायोरिटी. मतलब ऐसा मत बोलो फ्रेंड भाग गया. अब यही इरिटेटिंग है. मतलब आप यू डोंट नो योर फुट स्विच एंड यू आर सिटिंग हियर. अरे एक्स वाई से सेंटर करो ना. When you are free after OT, why don't you sit down in this microscope and learn the foot switch? Zoom कम करो. ये फोकस है. टिप रखो वहां. इरिगेशन ऑन करो. Identify the incision. Bevel down. Bevel down. Irrigation on. अभी एस्पिरेशन नहीं चाहिए. एस्पिरेशन नहीं चाहिए. Then bevel up. You move the eye and head. Aspirate. Don't move. Power. Power चलने दो. ज़्यादा नहीं लाओ, अपने आप आएगा. Power off. Power on. Don't move too deep. Power on. Off. Aspiration off. Come out. Irrigation off. Let me come. इसको दीजिए. आइए. This is not a suitable microscope for training actually. The observation tube doesn't have any stereopsis. It's very difficult to judge. Nothing is moving. ये चोक तो नहीं है. We have a nice PC rent here, and we don't have reflux switch. कटर दीजिए, विट्रेक्टमी कटर
Vitrectomy.
लगा नहीं क्या? इसको दीजिए. इन्फ्यूजन
कैमरे में देखो सर.
और किस चीज़ में देंगे? Bit लगाइए. Now why do we need vitrectomy during removing vitreous? Because vitreous cannot be aspirated. So you can cut it, but you cannot pull it. So that is why you need vitrectomy. Otherwise you will not be able to pull anything. इरिगेशन ऑन करो. फुट स्विच पे क्यों नहीं है? अरे जवाब दिया करो भैया, तुम लोग सवाल पी जाते हो. मैं कुछ पूछ रहा हूँ. मानसी कहाँ चली गई? कहाँ है मानसी?
मानसिक
अभी नहीं.
सर बुला.
इन्फ्यूजन ऑन का स्विच कहाँ है? अरे फुट स्विच पे. Now removing this vitreous is very important, otherwise this opening will keep on gaping. More and more vitreous will come. But at the same time you want to preserve the capsule. रोशनी में देखिए. आइयो लाइए, इसको दीजिए.
लेंस खोल दीजिए.
This is the problem with training part. A simple case turned into a complication, and you just can't help it. And that is why people are not so keen to train. Who is going to pay that price? And there is no easy way out of this. So a patient who would have been finished by right now and with no event now has a large tear in the PC rent. What is the answer? आइए लाइए. So even if someone dares to let the student learn, these are the events. And I can't blame anyone, either you or someone else, because it's part of the game that you will, when you learn the. वो वाला स्विच कब आ रहा है जिसमें रिफ्लेक्स है?
सर आ जाएगा. 26 किलो गया तो क्या थोड़ा सा टाइम लगेगा.
देखो कितना गोलमोल जवाब है. आ जाएगा, थोड़ा टाइम लगेगा. मैं पूछ रहा हूँ कितना टाइम लगेगा? आप हमें बहला रहे हो. हमें मालूम है मैं क्या पूछ रहा हूँ, आप बहला नहीं पाओगे. उनसे डेट पूछो. वो आपको बहला रहे हैं, आप हमें बता रहे हो. So now we have only the sulcus, which is a safe place. I don't want to go into the bag right now, although I have this inferior part. So we have this intact part inferiorly. Oh, superiorly we have a rent, but I don't want to take that chance. A dialer दीजिएगा.
Yes.
I can see that here we have some notching of the PC, so that indicates that there is some vitreous entangle in my side port. So we'll sweep it across so that I can take care of this, and we'll go into the sulcus. Now sulcus के लिए best bet ये quadrant है, where you have both PC AC दोनों. So we'll direct our injector into that quadrant, not like this. We'll go like this. So it is right over the capsule. Push the trailing haptic in so that the IOL is not deformed, and then you dial it. In the meanwhile, the patient is taking deep breaths, making us aware that he is having some discomfort. Although this is not helping me, because then you would like to refrain from the movements which you want to make. But he is performing his duty well. Pilocarpine दीजिए. Pilocarpine and triamcinolone, they both act synergistically to provide you a clue that whether you have any vitreous tract in the anterior. TMA भी लीजिए.
TMA भी लोड करा दीजिए.
देखिए अगर फेको के दौरान विट्रेक्टमी मांगा किसी ने तो आपको क्या एक्शन लेना है? पाइलोकार्पिन मांगना है और टीएमए मांगना है. ये आपको आना चाहिए था. Pilocarpine make sure you are sure that there is no vitreous tract bridging across the PC rent and the incision site. And when you have a complication like this, when you have a complication like this, first thing is not to lose your calm, which most of us will do. Look, it's very difficult because then this backrest is going to hit me in a while. It'll come back like a spring. धक्का दे दो इसको backrest को.
One ml syringe
I don't want to happen when I'm in the inside the eye. ऐसे ही देखते रहिए. Now why do I dilute this pilocarpine? Is because pilocarpine causes ciliary body spasm. It will cause some more pain. So if you dilute it, and this effect is neutralized. We have some peripheral cortex, but then अगर visual axis clean है तो anti-inflammatory topical. Although that also can be removed, you have to make more effort, and you may compromise your capsule because see the vitrectomy cutter will cut vitreous, but will not spare capsule also. So you don't want that to happen. You want maximum amount of capsule to be preserved. Now I can see that the pupil is very round, no issue, and now we'll switch to our old technique of
iron.
now, like cutter दीजिए. कैटरेक्ट में TMA क्यों आएगा भाई? So I don't think we need to clean anything. It's a well-rounded pupil. There is some peaking, very suspicious peaking here. Cornea out करिए. Even that is not that bad. Dialer दीजिए. So if you think that you have vitreous bridging, then you don't push it. You cannot push vitreous. You cannot push a rope, but you can pull it. So this is what you do. So he's fine. I think we'll put in visco. We'll not remove that. We'll put in air, and you will start him on what? 3 anti-glaucoma, as we did in that last case. So you keep on learning. एयर चाहिए, TMA का हो गया. Now watch this recording and find out when did that rent occur. This is how you learn. Fine.